Hello, my name is Jaspreet. I am a second year master's student. Today we will discuss the urinary catheterization. The learning objectives for the today's class, we will, at the end of the presentation, we should be able to describe the indications for urinary catheters, uh, identify the types of urinary catheters, and explain the principles of asepsis, and discuss the role of a nurse in the management of a patient, and discuss the principles of urine specimen collection. So before we do any procedure, we always need some indications why we need it. Urinary catheterization is the placement of a tube through the urethra into the bladder to remove urine. This is an invasive process that requires a medical order and a sterile technique. Urinary catheters may be indicated for a short term, up to like in 2 weeks or less, or a long term, which means like more than 14 days. Conditions that require use of urinary catheters include the need to monitor urine output when we need to know the ins and outs accurately, relief of urinary obstruction. There could be, since excessive accumulation of urine in the bladder increases the risk for urinary tract infection. And other causes like having a urinary obstruction can lead to the backward flow of the urine up to the ureters and to the kidneys, causing a kidney infection or the damage. Other situations when a catheter is required include like in a surgical procedures, either intraoperatively or post-op. So also, sometimes we need to instill the medication into the bladder, or the patients within neurological conditions that leads to the bladder not emptying properly. Sometimes we use this for the patient in end-of-life care as a comfort measure as well. And there are in-out catheters. So these are also a short-term catheters, may be required for the patients in a urinary retention, like in a one-time relief, or for the collection of a urine specimen for the urine culture when a sterile sample cannot be collected with other means. You might have heard about urinary incontinence, which is an involuntary leakage of a urine. So we don't normally insert a urinary catheter for this condition unless the urine leak interferes with the wound healing. So, or the urinary incontinence is prolonged. For pressure ulcers or perineal breakdown, an indwelling urinary catheter may be needed as we want to keep the area dry for faster healing. So, in last week we talked about wound vac. So, if the patient is having a wound vac in the perineal area, there might be catheter insertion to promote the healing or to prevent the disruption of the integrity of the dressing. Next is use of a bladder scanner. In the clinical area, you might have heard the terms PVR or the bladder scan. The machine and the technique you use for these two procedures are the same. However, PVR means that the patient voided a certain amount of urine, but not enough, and there's a urine left in the bladder. So that is a post-void residual. In general, with PVR patients after the urinary catheter was discontinued, or for post-op patients who are still recovering from the effects of anesthesia, or patients with a urologic surgery. Now, if your patient have not been emptying bladder or having an inadequate bladder emptying, suppose your patient does not void at all during a shift, you might want to check what's happening. So you might do a bladder scan to see whether they're dehydrated or they're retaining urine. So basically, after every void, if you do a bladder scanner, it is called post-void residual. But if you do randomly, then it's called bladder scan. This procedure is very simple, non-invasive, and you can perform it if required. So you may have an order for it, but there are situations based on your nursing judgment. You may decide to do a bladder scan. The procedure involves, first foremost thing, you need to inform the patient about the need for bladder scan. Patient education comes up first, and you need to receive a consent. Once the consent is removed, you will collect the supplies. It involves the bladder scanner machine itself, uh, gloves, and a towel to clean, and ultrasound gel. So you will apply the ultrasound gel on the patient's lower abdomen above the symphysis pubis. Place the scanner head on the gel, apply slight pressure, and point scanner head slightly towards, tilted downward towards the bladder. Uh, you might need to adjust the head. It will display on the screen that you need to move the head of the scanner to get an appropriate reading. So once you achieve an centered position on the scanner, you will do a few measurements, usually 3 measurements, and look for the higher volume. And you will see on the screen of the scanner. Once you are done, clean the gel, make sure the patient is comfortable, document your readings, and report the findings to the appropriate service provider. So now, based on the result of the bladder scanner, you might receive an order for a catheterization. So there are different types of catheters. They could be based on the types of lumen. It could be a single lumen. It can be like in a frequency, like an intermittent or indwelling catheters, and or long-term or short-term catheters. So single lumen catheters are usually intermittent catheters. They are used for insertion of a catheter for one-time bladder emptying, whereas indwelling catheters use double lumen or a triple lumen catheters. So double lumen catheters designed for indwelling catheters provide one lumen for the urinary drainage and a second lumen to inflate a balloon that keeps the catheter in place. If you look at figure 2, the cross section of the catheter will show you there is a presence of a tube. So if you look at the image figure B, there are 3 lumens. So one lumen is for balloon inflation, the second is for urine drainage, and the third is irrigation of the solution that flows in. So indwelling catheters material is made from different materials as well. It could be latex or silicone. So some have a special coating that reduces urethral irritation and incrustation. Straight or intermittent catheters are made of a rubber. It is usually more softer and more flexible. So patients who self-catheterize have a large selection of catheters, some with special coatings that do not require lubrication and others that are self-contained systems, consisting of a lubricated catheter and packaged with a connected drainage pipe. A cootie catheter is also available for men with an enlarged prostate with a urinary obstruction. It has a slight bent tip designed to navigate past the obstruction. So indwelling catheters come in a variety of the balloon size. It could be 3 ml to 30 ml. 3 ml we might use in the child because their bladder size is small, and we might use a 30 ml for the patients who's getting a continuous bladder irrigation. The size of the balloon is usually printed on the catheter port, like you can see here. The recommended balloon size for an adult is a 5 ml. It will say 5 cc, but you can use that 5 cc balloon can be filled with a 10 ml of a syringe. And the long-term use of a larger balloon, that is 30 cc, has been associated with the increased patient discomfort, irritation, trauma, and increased risk of a catheter expulsion. It can also lead to the incomplete emptying of the bladder because of urine that pulls below the level of a catheter drainage lumen. The size of the urinary catheter is based on the French scale, so which reflects the internal diameter of the catheter. Most adults with an indwelling catheter should have a size 12 to 16 to minimize the trauma or the risk of infection. Older women or older men with an enlarged prostate may need a smaller catheter, and whereas the larger catheter diameters increase the risk of a trauma to the bladder, neck, and urethra. However, large sizes such as 20 or 22 French are needed in special circumstances, such as a urologic surgery or in the presence of a gross hematuria. Smaller sizes such as 5 to 6 Frenches for infant and 8 to 10 Frenches for children. So now what do you need for this procedure? First of all, we need a catheter and a catheter kit. So sometimes there is a pre-assembled catheter kits that might contain a sterile item like a tray, drapes, lubricant, iodine stick for cleaning, pre-filled syringe with the sterile water to inflate a balloon, um, and sometimes it may contain a specimen container or the sterile gloves. These kits may differ depending on the hospital. But if you do not have a kit in your clinical area, you need to collect these items separately, and you need to grab a sterile gloves, sterile drainage tubing in a bag, and a stat lock. It's a catheter strap or other device called stat lock. Um, then you also need a clean gloves, flashlight, or another light source. So sometimes we need an additional person based on the patient's ability to take a position. So we won't go over the procedure now because you will practice it in the lab. However, there are some important things that you guys need to remember. First, the key concepts. This is a sterile procedure and it requires sterile technique. The reason is that we don't want to reintroduce any bacteria in the bladder. Therefore, hand hygiene and the use of sterile gloves are a must. Once on your hands, the sterile gloves can only touch sterile objects. But I'll mention it is important that once if you are doing an intermittent catheterization, one-time use, it is a clean, do not touch procedure. Next, since this is an invasive procedure and requires exposing the genitalia, so therefore promoting patient's dignity and comfort are paramount. Patients should be placed in a comfortable position. Make sure you minimize the time patient's perineal area are exposed, provide privacy, and talk to your patients throughout the procedure. Explain them what is going on, and at any point in the time patient experiences discomfort, you need to stop the procedure and do not force the insertion of the catheter. So to stop the procedure when the patient's discomfort means here, since this is an invasive procedure, we expect the patient will have some sort of a discomfort, but you need to assess if it's a little bit of discomfort or patient is in a pain or agony. If then you need to stop the procedure. Next is assessment of a catheter. Patients with Foley catheters require special attention because there are risks for developing catheter-associated UTIs. So those are usually caused by E. coli, which is the major colonizer of the bowel. Thus, fecal incontinence increases the risk for UTI. And in order to reduce the risk, it is important that we provide regular perineal hygiene. We need to assess the patient so we can prevent the catheter-related trauma and remove catheters as soon as possible. Assessment of perineal area is a part of your head to toe assessment. So you will look at the insertion site, observe for any discharge, redness, bleeding, or presence of a tissue trauma around the urethral meatus. Then you need to follow the catheter and the drainage tubing to the collection bag. And we assess the color, consistency, amount of the urine. Make sure do not forget to assess the odor if there's a presence of odor in the urine. Perineal care is very important, and you can use mild soap or water or warm water when you clean the catheter, but do not pull it so that you're not creating discomfort for the patient or damage the urethra or the bladder neck. Next, as we just discussed, prolonged indwelling catheterization is a major risk for UTI. So as soon as the catheter can be removed, we need to remove it. So, but you will need an order for that. But catheter removal is within your scope of a practice, although this is way easier than inserting a catheter. But there's a few steps that you need to follow. First, we all know we need supplies. So you need a gloves and a syringe, depending on the size of the balloon. If it's a 5 cc, you might need a 10 cc syringe. If there is a 30 cc balloon, then you might need a 20 or a 30 cc syringe. And you will need an incontinence pad and first of all, you also need to inform the patient. So once you inform the patient and you are a patient is in a comfortable position, this procedure is not usually uncomfortable for the patients, but you need to inform that it might be they might experience slight discomfort when they're pulling. So when removing an indwelling catheter, it is important to ensure that the catheter balloon is fully deflated to minimize the trauma to the urethra. So like in a picture, you attach an empty syringe to the balloon port and deflate the balloon. Once the balloon is deflated, you can pull the catheter out. Do not forget to do a perineal care after. After catheter removal, all patients should have their voiding monitored for at least 24 to 48 hours using an in and out sheet or a bladder diary. So record the time, amount, including if there's an incontinence as well. So use a bladder scan to monitor bladder functioning by measuring a post-void residual. We know that the risk of a UTI increases with the use of an indwelling catheter, and sometimes the symptom of infection can develop even 2 days after the catheter removal. That is why it is important to inform patients that there is a risk for infection and they need to take the preventive measures like perineal hygiene and also the sign and symptoms. So the sign and symptoms might include strong and persistent urge to urinate, burning sensation, frequent or small amount of urination, cloudy colored, cloudy or foul smelling urine. In a woman, there might be pain over the pelvic area and a fever, nausea, vomiting. So if there's any sign and symptoms present, they need to inform to the primary care provider. Next, there are some do's and don'ts based on the principles of asepsis. So we all know 4 moments of a head hygiene. So before you touch or after you touch the catheter or the urine drainage bag, it is important. We do not want to contaminate the catheter or the drainage bag. It is also a very good idea to wear disposable gloves even when touching the drainage bag because there could be a leaking. You don't want anybody's body fluid on your bare hands. So aseptic insertion and manipulation. So always use the aseptic technique when inserting a catheter. You will be using sterile gloves, and if anything gets contaminated, you need to discard and restart the procedure. And you also need to monitor Foley, and make sure like you secure the device in a place. This will prevent pulling and trauma to the meatus, especially for male patients. But you have to be careful when you're using a stat lock. Make sure your tubing does not get pinched because that will stop the urine flow. Then there is a perineal care, daily and PRN with soap and water. We have already discussed that. If the patient is able to do independently, provides the supplies and let them do that. Also maintain the sterile closed system. Never instill anything that is not sterile through the catheter. A break in the catheter system can lead to the introduction of microorganisms into the bladder. Next, keep Foley bag below the level of a bladder, but off of the floor. If you enter into the patient's environment and see there is a Foley bag on the floor, make sure you hang it. This is very important because indwelling catheters drain the bladder by gravity, and attaching to the bed frame prevents accidental pulling of the catheter when a bed rail is lower. Bags on the floor may lead to accidental pulling of the catheter or spilling the urine. Another thing is important whenever you do your assessment, look for a presence of any tubing kinks, dependent loops, because if they occur, the drainage will be impaired and the patient will end up with a full bladder. So you need to empty urine bag regularly into the patient's own container, like label the container that you are draining without containing the drainage spigot. This is usually done at the end of the shift, but you might need to do it earlier since the patient is draining a lot. Do not wait until the collecting bag starts bursting. So when you empty the bag, the volume of urine should be recorded on in an inch sheet. And next, Foley catheters are not changed on a routine basis, but when there are long-term catheters, there are usually in a standardized orders, and it is also recommended by the manufacturers to change the long-term catheters every 30 days. So you have to note down that date, that when the last catheter was changed. Remember that every time you insert something through the urethra, you are potentially introducing bacteria in the urinary system. But there are some don'ts. Do not pre-test or pre-inflate balloon before insertion. It is best practice because it can form a cuff on the catheter that may injure the urethra. So if you look at if you see in the clinical environment, in the clinical area, some of the nurses inflate the balloon to check the patency. So please do not follow them. Make sure you do not, because this is the evidence-based practice. When removing Foley, do not pull back on a syringe to remove the fluid from the balloon. Let it empty by passive deflation. The pressure of the saline into the balloon will push the plunger of the syringe back. If you pull, you might burst the balloon and debris will remain in the bladder. And last but not least, do not cut the lumen off to allow the fluids to drain the bladder. The balloon is there to maintain the catheter inside the bladder. Next, as we said, a break in the system can lead to the introduction of microorganisms. On the image to your left, you can see the locations at the risk. The site of the catheter insertion, the spigot, the tube junction, the junction of the tube and the bag. And the second image shows you the parts of the balloon clearly. That's usually in the clinical area your catheter bag will look like. And the image on the right shows you how to empty the urinary bag. But sometimes in the clinical area, there is a urometer attached to the front of the um, this bag. So it is a plastic square, like a little box that is attached for the accuracy when the patient is in OR, ICU, or observation room. Next is complications of urinary catheterization. We have already mentioned that the most common complication of a catheterizations are the UTIs. So healthcare-associated UTIs is the fourth leading cause of a healthcare-associated infection after pneumonia, surgical site infection, and intra-abdominal infections. So approximately 80% of a healthcare-associated UTIs are sorry, attributable to indwelling catheters. So what we need to do. So we have already talked about how to prevent the UTI. So, but there is a mnemonic for this that helps you remember what you need to do. That is called no Foley. So N stands for never should Foley touch the floor. O indicates for only indicated Foley catheters stay in. So as soon as there's an order to to remove the Foley, you should take the Foley out. Foley care a minimum daily with a soap and water or PRN. Open systems only for obstruction, but if there is, it's only for drainage, you need to use closed system. Loops and kinks, avoid them. Every patient has own labeled container, collection container, and you must secure the Foley like a stat lock device preferred. So let's talk about some scenarios. What if? What if the sterility is broken during the catheterization, either by nurse or a patient? So what you need to do. So if an equipment or the supplies become contaminated, we need to replace with the sterile items or start with the new sterile kit. Um, Sometimes it happens that the catheter goes into vagina during insertion. Uh, so we can leave it there for the moment, and we need to clean the urinary meatus again and use another catheter and reinsert the sterile catheter into the meatus. Next is like sometimes patient will complain of a bladder discomfort, and you assess the catheter is patent and there is a urine flowing. So what would you do? First of all, we need to check that the tube isn't pulling, because if the catheter is pulling, that could be a discomfort. Then you need to check if there's the skin around the meatus is not, there's no signs of infection. So then you need to notify that to the healthcare provider, because patient might be experiencing bladder spasms or symptoms of UTI. So those need to be treated. You need to monitor catheter output for the color, the clarity, odor, and the amount. Okay, so next, sometimes we will see the catheter isn't draining. So you need to troubleshoot first, check and make sure the bag is below the patient's bladder. It is not on the floor or it's not on the bed. And make sure there's no kinks or like dependent loops. You might need to like milk the catheter and check for the sediments in the drainage bag, because sometimes in the prolonged catheters, or if there is a presence of infection, you might see a sediments in the bag, and that can clog the urinary catheter patency. So if nothing works, inform the healthcare provider, and you might need to prepare to insert another catheter. If the occlusion is caused by sediments or the incrustation, it should be changed to avoid flushing debris containing bacteria into the bladder. So you would also monitor the patient for bladder distension. Next is like what if the patient has a cloudy, foul-smelling urine, complaining of chills, fever, flank pain, back pain, hematuria, urgency, lower abdominal pain, or a change in the mental status or the lethargy. So these are the sign and symptoms of UTI. So first and foremost, you need to assess for the bladder distension and tenderness, monitor vital signs and urine output, and report findings to the healthcare provider. Signs and symptoms may indicate UTI. So I talked about the one symptom, the change in mental status. It is more common in older adults that the UTI can cause delirium in the patients. Next, what if the patient is unable to void after catheter removal? Patient has a sensation, try to strain to void, or only like in a urinating small amounts. So first of all, you need to assess for the bladder distension. If you can, like, if you palpate the over right above the symphysis pubis, you can feel there's a hard ball if there's a retention of urine. Help to normal position for avoiding in privacy, because sometimes like people cannot. We just give them a, hey, there you go, there's a bedpan, you can use it, but they cannot pee because that's not in a natural position for the patient, or you will give an urinal to the male person, so they might not be able to pee. So you need to see what's the safest way to provide them a position that's close to the natural position. Make sure you provide privacy. Perform a bladder scan to assess for excessive urine volume in the bladder. If the patient is unable to void within 6 to 8 hours of a catheter removal or experience abdominal pain, notify healthcare provider. There's another thing that you need to check as well, patient's hydration status. So if the patient is drinking well, patient may be dehydrated. And what if there's a blood in the urine? So depending on the cause, but assess for the shock, like in a vital signs, skin color, moisture. But sometimes you need to keep in mind if the patient has had any urological surgery immediately after the post-op, sometime there the presence of blood in the urine is expected. So you need to understand that. But if it is not that case, you need to notify the healthcare provider, and patient may require bladder irrigation. Next is the bladder irrigation. Sometimes it may be necessary to irrigate an indwelling urinary catheter using a triple lumen catheter and sterile solution that is usually a normal saline to maintain the patency, especially after urogenital surgery, or to prevent blood clots from occluding the catheter. This is usually done by continuous closed bladder irrigation. Occasionally, an intermittent closed irrigation may be ordered if the catheter is occluded and it is deemed harmful to remove the catheter, like after urological surgery. A prescriber may order a bladder installations for select bladder medications with instruction to how long the medication stays in the bladder. So unnecessary catheter irrigation should be avoided because it can cause the introduction of microorganisms. If a catheter becomes occluded by sediment or incrustation, it should be changed to avoid flushing debris containing bacteria into the bladder. Bladder irrigation or washouts to unblock such catheters that break the closed urinary system increases the risk of the urinary tract infections. Next is the urine samples. For specimen collection, we need to collect the random, clean voided, midstream, or the timed specimens, depending on the reason for the specimen. For a urine culture, you need a sterile or the clean voided sample, whereas for routine urinalysis, a random clean void should be fine. Sometimes 24-hour urine is needed to help diagnose kidney problems. It is often done to see how much creatinine get cleared through the kidneys. It could be done to measure the presence of protein, hormones, minerals, and other chemical compounds. If a urine sample is needed, make sure you find out which test the urine is needed for and collect accordingly. That is the end of the procedure. End of the lecture. I would remind you to do the knowledge checks. That will be opening Friday. Please, we cannot emphasize enough because you guys need to do those quizzes to pass the course. Thank you.